Lastly, we'd like to call Dr. Ajay Sharma for his talk on recent cutting-edge innovations in HPB, bile duct, and gallbladder.
Good morning, everybody. I bring regards from my institution, Mahatma Gandhi Medical College, where we are working right now, and the institutions where I have got trained, Sanjay Gandhi PGI and my MBBS at SP Medical College. The recent cutting edge innovations of HPB is the topic. I'm thankful to the organizers, because if I ask my audience to raise a hand, how many of you do a liver transplant once in a week, we'll have only 10%. If we ask how many of you do PD once in a week, maybe you will have 30%. But if I ask audience how many of you do a gallbladder and a CBD, I think it will be 100%. So I have a topic which almost 100% are involved. And with the senior colleagues in front, senior teachers in front. Okay. So, laparoscopic cholecystectomy, we know it has been from 4 ports to 3 ports, every edge with 2 ports, then single port, then single incision, then needle scopic. But presently, I think it's robotic. Notes is presently no more very much into vogue. So, I think my area of interest would be robotic as compared to a laparoscopic cholecystectomy. Robotic cholecystectomy has actually failed to prove any clinical, failed to prove any significant advantage over a laparoscopic cholecystectomy. Lap chole we all have been doing for so many years. We know it's 4 ports, simple, standard. With robotic coming into picture because of market or industry, I think we have now gone more into robotic cholecystectomy. It's still having some error. The data shows that it is having a higher complication rate, higher incisional hernia rates. Need some correction, I think. Continue. That robotic surgery, the major problem with, how many of us are doing robotic surgery? Can you raise hands in audience about robotic chole? Simple chole. I'm not asking about any advanced procedure. So we have only few people in the audience. So let me tell at least those who are doing it routinely, they would agree that the problem with the robotic, we are using a Da Vinci system, and the problem with Da Vinci system presently is that the instrument, we are in a habit of using a Leahy's forceps, a hook for cautery, and then subsequently clip applicator. But if you see in robotic, you can use only 2 instruments at time. If you change that instrument, that adds extra 75,000 cost to that step. So if you change that, is my time running out? No. So I can discuss in the meantime. Fine. So if you change the instrument, it adds extra cost to your thing. So a simple lap chole, which may be done at a very less cost, will add extra cost for a single change of the instrument. If you do it with a hook, you can't complete the procedure, because with a hook you can't dissect in the Carot's triangle. And if you want to do it just with a Maryland, you can't do the entire procedure with just a Maryland into it. So you'll change my slide? I'll have to ask you to change. Okay, fine. So what has happened is now robotic has failed to prove any advantage at the present status. It is shown to have higher risk and no additional advantage, because standard 4 ports, that also has 4 ports. There is no decreased number of ports. Next, please. This is the data which was published in 2024, which has shown, compared the two, and has shown again, lap chole is more safer and better. Next, please. Next slide. Yeah, so they have done a trial which was in, up till 15 September 2023, included many studies. Next. The data is from 2019, 2018, 2017, 2016. So till that time, the robotic was showing to be having more failure rates. Next. You see the cost involved. Next, please. And this all favors laparoscopic cholecystectomy. Next, please. So what they have concluded is randomized control trial failed to prove, robotic cholecystectomy failed to prove any clinical advantage over lap chole. So lap chole is not very favorable if you try to do it robotic. So that is the cutting edge which was actually a robotic is not very favorable for. So this is what I start with the negative thing. Next, please. More trials comparing safety, it is not also safe. Now, I don't know how many of you have heard that lap chole, robotic chole has a higher incidence of complication rate as compared to a simple lap chole. Next, please. This shows that robotic assisted cholecystectomy was associated with a higher rate of complication rates, especially in terms of incisional hernias and in terms of vascular injuries, and moreover, and the patient, and for the patients who underwent cholecystectomy for acute and chronic cholecystitis, it is more difficult. For a simple chole, it might be easy. And bile duct injury rate is higher in a robotic chole, that has been shown. Next, please. Next, please. There was a change in this entire system when this is actually a true cutting edge, which has shown some advantage, which has shown a true advantage that you incorporate the image. This was done with CT scan. You incorporate the image into your Da Vinci screen, and you can see the restructured image. And when you are doing a cholecystectomy, you can compare the both. And at the time of chole, you can see actual image on your screen. This will come in some time. What is the extra advantage? So these are all advantages of an artificial intelligence in surgery. Next, please. Second comes is edges of ICG. ICG in lap chole we are all using. I think many of our audience must be using it. So usefulness of ICG is actually there was a infrared that you give a contrast IV 1 hour prior to it in a particular dose, and then a near infrared that is excreted in the bile, you see the image. Sorry, I think please previous one. So we have a better visualization of common hepatic duct, cystic duct. That is the impression. It is safe, it has a shorter operative time, it has a lower cost, and all young surgeons can practice it for a safe lap chole. The problems is that this contrast is only seen up to 5 to 7 millimeters. So you can't see the intrahepatic duct, specifically the right hepatic duct if it is going close to the gallbladder bed. The cystic duct before the dissection may not be visualized well. So you have to dissect. I'll again come into subsequent slide that you have to dissect the cystic duct prior to doing it. Next, please. Now, this is actually our goal is to see a critical view of safety, and Srikanth has shown that this second line that the CBD clearly visualized the ICG only after the initial dissection of the hepatocystic triangle. If you don't dissect that, it gives you a false impression. So this is called as NIR blind period, when you think that everything is good, but actually it is not that good. Next, please. This image classically shows, the A picture shows that you are actually not able to clearly visualize the same thing which you are seeing on C. So that is actually a near blind period where you are under a false impression that it is actually giving you a critical view of safety. So it is a risky area. Next, please. Second area is when you have a complication. In the presence of acute cholecystitis, the ICG is actually gives you a poor visualization. It gives you all green. It gives you a entire picture to be the same. And in this picture, which is showing a cholecystodiodnal fistula, it is actually overlapping your Quelet's triangle. So this is second area of problem with the ICG. Next, please. So if you see now, now we go to CBD exploration. That was ICG with a routine procedure. CBD exploration can be done by robotic as well as by traditional. Next, please. Traditional open, then lab, and now robotic. Next, please. We need 2 extra ports to do a transcystic or a direct CBD exploration through by a robo. Next, please. The simple adjuncts are going to help us in a robotic surgery. The problem is if you want to place a C-arm, it is not possible. It is difficult with a robotic surgery. So the adjuncts in the form of a laparoscopic ultrasound or in the form of a firefly fluoroscopic guided images, that is going to help us in a CBD stone exploration by a robotic surgery. Next, please. We'll be talking about a very common benign condition, benign biliary stricture. There's a good article from Jodhpur AIIMS. Next, please. Which shows that a benign biliary stricture, specifically if you have a common stump, then it can be done by laparoscopic, by a robotic procedure. The advantage, why we do it open is because we need a very close value of safety. We have to do a good anastomosis. If you have a robo, that can gain an advantage over it. Next, please. This is a very good article by Jipmer, and Kalai has shown a very, he has elaborated this. Next, please. That how it is, it can do, you can do an anastomosis for E1 to E3 strictures by a robotic procedure. The advantages, extra advantages above a routine hepatococcygeostomy with a robotic is that when you are doing it with robotic, next please, you can have an augmented reality visualization or you can have an intraoperative ultrasound and you can use ICG to identify the bile duct which you are not doing it in open surgery. Next please. So future, if you see, so for next generations with this, you have AI associated robotic systems which will be coming up. We'll have more affordable robots, which Dr. Namesh said just now. And we have chemotherapy which can be targeted in coming time with AI and development of the bioengineering in the bile duct pancreatic tissues subsequently with AI. Next please. Now remote telesurgery, yes, it will be feasible with the AI. And with AR assistance, we can have a visual image on our monitor. Presently, we have to see a C-arm, which we have to see on one view, and a laparoscopic surgery on one view with a robotic, and it included in the same image. I think this virtual image visualization will help us in subsequent future. Next, please. Next, please. So we started robotic coli. We did some few procedures coli. We were not, at least I am not very happy with robotic coli. Added cost and added procedure time. Next, please. So with that, I would like to thank all my audience for your patient listening. For a common topic, I wanted to cover only benign. I thought somebody would be covering it on malignant as well. But there is a wide, more vast area if you want to cover in malignancies of bile ducts, whether it is hyalocholangiocarcinoma or whether it is lower CBD cholangiocarcinomas, robotic and AI is going to give you a much more help. Next, please. With this, I would like to invite you all for next IHPBA, the theme being precision and progress of HPB surgery. We actually, Dr. Namesh, we all as a team are going to organize this in Jaipur. You are all invited to Jaipur. I think it is a good weather and climate here in Calcutta with the beautiful rains. I think we'll be able to offer you better climatic conditions in Jaipur and more areas for local sightseeing and local visits and a good conference academically. Thank you all for your patience listening.
Thank you, Professor Sharma.